Good afternoon. I'm Charles Shapiro, President of the World Affairs Council of Atlanta. Our program today is on racism and the future of public health. This is a follow-on to last week's Global Health Summit, which many of you attended. Today's program is underwritten by an anonymous donor and supported by the members of the World Affairs Council of Atlanta. I want to give thanks to the Georgia State University School of Public Health, the Kennesaw State University Wellstar College of Health and Human Services, Emory University School of Nursing, and the University of Iowa College of Public Health for helping us publicize this program. We've got 285 people registered from around the US and around the world. I want to give a special welcome to Bernard Taylor, who's the chair of our board of directors of the World Affairs Council. Her Excellency Thelma Philippe Brown, Ambassador of St. Kitts and Nevis to the US, Andrew Staunton, Consul General of the United Kingdom in the Southeast US, Monica Swan, the Dean of the Wellstar College of Health and Human Services at Kennesaw State, and members of the World Affairs Councils of Savannah, Georgia, Pittsburgh, and Olympia, Washington. Our panelists today are Dr. Leandris Liburd, Associate Director for the Office of Minority Health and Health Equity at the CDC. She sets the agency's vision for health equity, ensuring a rigorous evidence-based approach to the practice of health equity and promoting the ethical practice of public health in vulnerable communities. Linda Goler Blount joined the Black Women's Health Imperative as its president and CEO in 2014. The Black Women's Health Imperative is the only national organization devoted solely to advancing the health and wellness of America's 20 million Black women and girls. And Dr. Georges Benjamin, who is one of the nation's most influential physician leaders. He's been executive director of APHA, the American Public Health Association, since 2002. And he leads the association's push to make the United States the healthiest nation in one generation. Our moderator is Helene Gayle, CEO of the Chicago Community Trust, former CEO of CARE USA, an alum of the CDC, and a former director of the World Affairs Council of Atlanta. We're going to go to audience questions around 12:45, 45 minutes from now. So please submit your questions using the Q&A function. Please make them short and make them questions, not speeches. Helene, I'm going to mute myself and turn this over to you. I'll be back at 12:45. Over to you, Helene.
Great. Thanks so much, Charles. And it's wonderful to be here with three people who I deeply admire and also have been longtime colleagues as well as friends. So it's great. And I think there's a lot of ground to cover and really excited about this conversation. You know, and as I was listening to Charles as he made this introduction, talking about addressing racism and the future of public health, in some ways, you know, I would say that addressing racism is the future of public health. And as, you know, the COVID pandemic that we're still in the middle of showed the disproportionate impact on communities of color and so many of the challenges that we have faced where the spectrum of inequity has been highlighted and emphasized and made clearer. I think it continues to make the message that if we don't address these issues of racism, inequity, we will not be doing what we can to further the future of public health. So thank you all for being here. And maybe I'll just start with you, Leandris, representing the CDC. In April, CDC director did what many of us would have hoped could have been done decades ago. Rachel Walensky declared racism a serious public health threat. So just from the CDC perspective, say a little bit about what has that meant, both what has it meant internally to staff who, you know, many of whom have been addressing this issue or wanting to address this issue for a long time, but perhaps even more importantly, what has it meant in terms of what CDC will do to back up that statement in terms of how it addresses this as an agency.
Yeah, thanks so much, Helene. And also, I just want to extend just my gratitude to my colleagues that I'm here with today to have this conversation. And I want to thank the World Affairs Council for this convening. And it goes without saying that we've known for some time that that racism negatively impacts communities of color. We know that it has set up an intergenerational dynamic of poor health outcomes. And certainly COVID-19 has, as we say often, laid bare decades, if not centuries, of both health and social inequities. And so for us to continue without giving a strong focus to the impact of racism on both what we've seen as the severe burden of COVID-19 infections, severe illness, and even deaths in communities of color would really be counter to our mission as the nation's public health agency. And so we understand that we cannot build or contribute to building the healthiest nation if we don't confront these systems of health inequity head on. And so that's, I think, the principal impact and contribution of Dr. Walensky's declaration. I think, as I have heard informally from staff, they're, I'm going to say, optimistic, looking along with other parts of our country to see what that will look like in action. And so we are actually, right now, we're launching the agency's first health equity science and intervention strategy. And within that, a central focus will be around studying the impact of racism on health, contributing to what you all know is a very large and compelling literature already. And also, as we are working to incorporate health equity across CDC programs, across our data, our research, surveillance systems, and intervention strategies, then that is the way we will be approaching this. So we will leverage what CDC is most known for, which is its science. So that's our strategy going forward.
So I'd love to hear from both of you, Georges and Linda. What has this meant to you? And, you know, Linda, you were at the CDC, we were at the CDC around the same time. These are the kinds of things we push for and wanted to hear. Now on the outside, and George is from the APHA, who has long had a focus on inequity and race and racism in public health. How does this, what does it mean to have the CDC come out and make this kind of declaration? Whoever wants to go, Linda, yeah.
Okay, well, I'll start, and let me, you know, just add my thanks to Dr. Liburd as well for this conversation. It's certainly needed, and we need many of them. So I'm happy to be here with all of you to talk about this. And I agree with you. It is decades in the making, but it's here. The declaration has been made, and so you know, we now have that point of departure. So when we think about this, it sort of comes across as though this is something new. I mean, I'm sure all of you had similar experiences to me. Last year, I heard from so many people, oh, I had no idea health disparities was a thing. I had no idea racism was a thing. I had no idea they were connected. You know, we've been talking about this for some time, and there's decades of research. We can go back to Arlene Geronimus 30 years ago, who talked about weathering in Black women. Black women are literally aging faster than white women because of chronic stress due to racial and gender discrimination. I'm in Atlanta. Down the street from me is Tanae Lewis, who talked about the effect of racial discrimination at the DNA level and what that means to trigger our inflammatory and metabolic responses. So we can now look at diabetes and obesity-related syndromes related to racism and gender discrimination. The Black Women's Health Study found a causal relationship between racial discrimination and uterine fibroid tumors, low birth weight babies, maternal mortality, these things that we've been reading about for years in the news. And of course, with COVID-19, we saw, where did testing occur? Maybe it was often it was in places where Black and brown people and low income people could not get to conveniently. At times, they could not get to conveniently. We saw that with vaccine distribution as well. And going beyond the health sphere specifically, racism impacts our health in a number of areas. We look at policies. Red line districts in cities are 13 degrees warmer than non-red line districts in cities, and that impacts pregnancy outcomes. We know from a colleague of ours, Dr. David Williams, if we eliminated neighborhood racial segregation, we would eliminate health disparities and income inequalities. So from my perspective, as a Black woman who experiences what we call microaggressions, which don't feel so micro when I'm experiencing them, to my policy work and the work of the Black Women's Health Imperative, this issue is huge, and there's no part of our lives that's not impacted. We talk about the social determinants of health, but of course, we all have to ask ourselves why these social determinants exist in the first place. And so if we look at public health through this lens of racism and gender discrimination, it gives us an opportunity to rethink public health practice, to rethink public health policy, to rethink what happens in the exam room and in hospitals, in medical schools, in nursing schools, and what happens in the workplace.
Thanks, President Blount. Let me just build on what you said. When a leader of the nation's, in fact, the world's most prosperous prevention agency declares that a particular social determinant is an issue that we need to pay attention to, that it is a threat to our health. It's a leadership statement. And we know that it's very important for you to name racism. The problem we have is that people often don't want to use the R word because they think the sky is going to come falling down and the buildings will collapse and the earth will open up and swallow us whole. And the answer is that none of that occurs. What happens is enlightenment when you identify a problem. You recognize it is a problem because that's the first step to solving the problem. And we know that racism is about people's view about the value and human value of one group of people over another. And until we understand what it fundamentally is, and even if you're certainly not someone who hates another person or who has got up in that morning and decided to stigmatize another person, we all live in an environment that has been structured to give us these kinds of disparities and inequities. And so to have the CDC director make that statement tells us that the science is real and the science is there and the science is reliable. So that's how I see it as kind of an outsider who's not, who certainly had an opportunity to advise the agency on a lot of things, but have never certainly been an employee of the Center for Disease Control and Prevention. But I also think that it's important that the prevention word and in that title is clearly understood, because it also tells us that prevention can work here and that racism can be prevented, that there's something we can do something about. And so I see it as not only a leadership statement, but to me tells me that, okay, let's figure out what the root causes are and what the solutions are. And let's understand that both the science that says it's a problem to our health is there, as well as that means there are some solutions, and that we also need to do more research to understand the other solutions that we can do, that we can put in place to address it.
So, APHA has been talking about these issues for a while. And, you sit in our nation's capital and you work a lot with policymakers. How do you think this message resonates with the broader policy arena? And how is APHA thinking about taking this declaration and statement and really helping to further some of the policy mandates that you have as APHA?
Well, I think the first thing is we have to recognize that everybody does not accept it as a public health problem. They may accept it as a problem, but they may not accept it as a public health problem. And then there are some people who don't accept it as a problem at all. Racism ended at the end of the Civil War in their minds. It did not. Structural activities that have resulted in disparities have existed for some time. And, the American Public Health Association has worked very hard to make sure people understand that there are societal determinants that both help you be healthy as well as impede your health, whether it's transportation or housing, whether it's access to capital. All of these kinds of things impede your health. And when you apply racism to those social determinants, that means that somebody at some point, either inadvertently or purposely, put barriers in the way that ultimately result in inequities that prevent people from being healthy. So we know that communities, we had redlining, and even though redlining is technically not legal anymore, we know it still occurs. And if you follow the process of redlining, that not only does it create communities where everybody's living together and those communities then are devalued economically, they're the same communities that don't get the infrastructure dollars that they need to keep their communities whole and safe. And the value of those communities diminish because of that. But if you then think and follow that even further, once those communities get devalued, the prices of those houses get devalued. And when the houses get devalued, then they pay less property taxes. Less property taxes means less money that can go in those local schools. Then those schools don't have the funding to do well. That means those children don't get a good education. We know there's a correlation between education and your health. So if you follow this around, it becomes a never-ending circle and a spiral down for those communities, for the health of those people, for the well-being of the people in those communities, all because somebody decided to put a red line around those communities and in effect target them for destruction, for devaluation. And then when you ask yourself, why was that done? It was done based on race. And when it's done based on race, because they don't feel those communities and those people that live in those communities were valued, then we call that racism. And so I think the point is, people need to understand that while the original sin of redlining was there are many aspects of the redlining story that even continue today. When you have somebody that goes into a bank and isn't able to achieve the same level of capital despite the same job, the same income, the only difference is they're a person of color. So again, that might not be the way it was originally, it was originally designed to depress people. We have to acknowledge that. And that may not be the way we think of it 40, 50 years later, but it still occurs. And we have to understand that in order to fix that, then we have to do a range of societal policies to make sure things become equitable as we go forward. There's a science behind that, both on the physiological aspect, on the mental health aspect, and the sociology of it, that groups like the CDC can support, study, fund, disseminate, bring people together to understand. And APHA has been working on that kind of stuff, quite frankly, since our founding in 1872.
So lots to unpack. And Linda, I'm going to get back to you in a minute, and I want to hear, have the audience hear a little bit more about, racism in women specifically. But Leandris, let me turn to you, because I think some of the things that George has mentioned about the multi-sectoral nature of addressing this is a key issue. I went from public health to now really focusing on closing the racial and ethnic wealth gap and economic opportunity, because I recognize, we're not going to be able to really change the health impacts if we don't think about some of these economic. So CDC is a public health agency. It sits in the Health and Human Services Department. How are you all thinking about addressing this from a more intersectoral nature? Because we know that this is about the houses people live in, the jobs people have or don't have, the access to amenities, neighborhood development and economic vitality, et cetera. If racism is core to public health, how is the nation's public health and prevention agency thinking about how to interface and think about this in a more multi-sectoral way?
Yeah, absolutely. I mean, we will only be successful with strong partnerships with multiple sectors that actually have both the power and the leverage to shift policies toward greater equity. I wanted to speak to one thing that Dr. Benjamin said about, some people not viewing racism as a public health issue. And there are also, I want to speak to what Linda said about people not having seen health disparities, if you will, prior to the pandemic. And so, what we saw, for example, is that among those essential workers, in addition to the healthcare workers, those who worked in grocery stores and restaurants and construction work, transit drivers, people who could not work from home, over 70% of them were people of color. In occupations that did not provide paid sick leave, that did not provide health insurance, issues that within public health we have grappled with and advocated for a very long time. And so there are those who, in addition to not viewing racism as a public health problem, would also feel that the social determinants are outside of the purview, if you will, it's the language typically used of public health. Well, COVID has demonstrated that it's essentially absolutely not true, and that we can no longer remain in a lane of quote unquote health and with a limited understanding of that, and that we, as the nation's public health agency, will be bringing together partners from different sectors and actually working collaboratively in terms of our ability to share data and the associations between these social factors and health outcomes, and really working with them to help them see opportunities to leverage their influence to change policies and even within their own sector. So this will have to be a societal engagement. At CDC, we will not be able to do this by ourselves. Neither will all of the healthcare and public health enterprise. We have to have a multi-sector engagement, and we have to have the support of other decision makers and policy makers across this nation.
And, I am so thrilled again that Dr. Walensky made this declaration, but we all know that, one leader making a declaration and coming to a realization is not enough to sustain the momentum. And, I think of a dear mentor and colleague for many of us, Bill Jenkins, who for decades, talked about these issues inside of CDC. What do you think it's going to take for CDC to actually institutionalize this focus so that it isn't dependent on one voice, one leader, or even a group of leaders within CDC to make sure that this really remains a priority on the national scene?
Yeah, so as I mentioned earlier, the launch of the new health equity science and intervention strategy, which comes also at the direction of Dr. Walensky. Every division and CIO within the agency will have
CIO meaning a Center Institute
an office.
office, yeah.
Yes, the national centers, we have one institute and multiple offices, and there are divisions and branches within them. All of the divisions are being asked to submit by July 31st a health equity plan. And, they certainly will have the discretion to identify, the health issue that they want to address. But we have been working literally 24/7 for a number of weeks to lay out parameters, if you will, and we'll be releasing many of those this week. So all of that to say that there is an expectation and an accountability to address this issue and others related to health equity that has not existed before. So we have expectations, we have standards, we have deadlines, and we have the full support of the Office of the Director. And so for those, Helene and Linda, if you know the power of that within CDC. Now, I think where we also have to be thoughtful and strategic is to take advantage of this opportunity and then truly institutionalize the work that will come out of this strategy so that as leadership changes, as other things change, we will still have the foundation within the agency's programs to continue this work. I always think I can't imagine ever a CDC without epidemiology. It wouldn't happen. So let's imagine that we would have a CDC for which health equity is as much a part of its core as epidemiology.
Great. That is incredibly encouraging and inspiring, actually. So let me turn back to you for a minute, Linda. When Black Women's Health Imperative has an incredible history and an incredible legacy, and you're doing such great work at this intersection of gender, race, and health. How do you see it playing out? And I think about some of the great reporting that people like Linda Villarosa has done around maternal health and what the impacts have been. How are you seeing it playing out, and how has the Black Women's Imperative thought about the intersection and how you want to embed that in the work that you do?
Yeah, thank you. That's a great question. I mean, this term intersectionality, it has been around for a while, about a little over 30 years, where we like to say, we just describe it as Black women sort of live at the intersection of racism, gender discrimination, and economic oppression. So that is really kind of what gives rise to the kind of health status that we experience. And for almost 40 years, the Black Women's Health Imperative has been working to make that knowledge apparent to everyone, but then provide the research, the policy work, the tools and strategies to help Black women overcome that, but also get the policies in place to help eliminate that. And I mean, it's been quite a journey. And I go back to 1985 with the Heckler Report, which was really the first administration report on health disparities. And while it was a great work, we know now, some almost 30 years later, health disparities are worse in many respects. In the last 35 or so years, over $200 billion has been invested in health disparities research and programming. And yet here we are. So, there's a lot to be done. I'm encouraged just by our own experience with CDC. We happen to be a grantee to work on the National Diabetes Prevention Program. Our work is actually a leader. We have the best results. And that is because of the way we're implementing the program. But what's encouraging is in our conversations now with CDC leadership, they're saying, oh, right, the way this model originated actually left out people of color and made certain assumptions about the way people live and the kind of discretionary income they had, the kind of jobs they had, the kind of freedoms they have that are in fact not the lived experiences of Black and Brown people. And so in that sense, we have now modified this program, changed the curriculum at CDC's request, and are rolling this program out to communities and having much greater success than we saw in the past. So I'm encouraged about the willingness to listen, to look at science differently, look at new science, to partner with organizations that are doing things a little differently. But also when we think about health, a lot of what is at play now is how we even talk about health and health data and race and gender. I mean, we saw this with COVID-19. We weren't even reporting a fair amount of data by race. So what we've undertaken is trying to change the language. We've got a partnership with Healthline, which is the leading internet health search site. It's bigger than WebMD, to train their senior editors to look for racism in the language of what the writers are producing. They have millions of readers every week. And so what shapes our perception of people is obviously what we read in our health, if you're looking for health information. So we're 3 months into training them on how to spot racism, how to understand the historical context of what is being discussed, how to talk about race and data, so that what gets presented to their millions of readers is actually accurate and grounded in history. We're doing something similar with rare disease to help these researchers and clinicians understand what participation means, what the experience of participation of people of color, women of color in particular, means, how to fund more of research related to diseases that disproportionately impact Black and Brown people, how to improve the pipeline, how to get more clinicians of color, and how to broaden their social networks so that people of color are included in clinical research, but also that the outcomes are what we need. And one other thing I'll mention is, we've got to step back and look at what racism means. There's some research out that shows that if magically tomorrow we could end racism, it would mean about a 20% pay increase for everyone. And so as we talk about this, as you all know, we end up sort of talking about a group of people and it becomes this group of people's problem to deal with, when in fact racism adversely impacts everyone. And so if we can take a step back and from a health perspective, understand that everybody's health benefits if we don't have racism, if we don't have gender discrimination, and begin looking at it that way, putting those policies in place, changing the way we conduct research and think about research and talk about these issues, then I have some hope that we can actually make some progress. But as of right now, to echo George's, this issue becomes, it instills fear in people because there's a group of people who feel like they're going to lose something if we make any progress in this anti-racism effort. And we have to actually help people understand that that is not the case. We actually do benefit, but there's that hurdle, that fear is enormous, and it's going to take all of us to help overcome that.
Yeah, I think you make an incredibly important point there. I mean, you made a lot of great points, but there's a wonderful book, if people haven't read it, Heather McGhee, The Sum of Us, how racism hurts all of us and how it helps, I'm forgetting the whole title, but how it helps us all. And whole focus on this zero-sum mentality. She talks about it much more from the economic and overall perspective, but I think it's very clear from the health perspective. When we look at the U.S. statistics, whether it's maternal mortality, child mortality, infectious diseases, we're hurting in terms of where we stand as a nation in our health statistics because we haven't thought about these issues of equity and race in a serious way. So I think it's a incredibly important point. The other point that you touched on that I'd love to get other perspectives on is, how do we bring the voices of community into our response? When I was at CDC, we developed the Minority AIDS program, which was one of the first times that we directly funded community-based organizations. And I can say it totally changed the nature of our response because we brought the voices of community into the room. So I'd love to hear you say, Leandris, anything about how you're thinking about that. And George's, even though you're an advocacy group, you're not a on the ground programmatic implementer, I think APHA has done a great job in really listening to communities and bringing the voices in. So I'd love to hear your perspectives on that as well. But Leandris, maybe start with you.
Yeah, absolutely. So last year, at early in the response, in the COVID response, we stood up the first Chief Health Equity Officer role and function. This was the first time in the agency's history that there was this role. And I was able to step in as the inaugural Chief Health Equity Officer. And even before assuming that role within the Office of Minority Health and Health Equity, we wrote proposals that we submitted to the response to fund two national minority organizations that we knew had reach and connections into local communities across the country. And we also funded the CDC Foundation so that we could get access to historically Black colleges and universities, and also majority institutions that had established relationships with communities of color. And so immediately we understood that we had to engage trusted messengers. We had to have an intentional and robust community engagement and community-based organization approach. And that has continued. I have to say that there have been numerous at this point national organizations funded that are reaching into local communities. And just this year, $2.25 billion, the agency's largest commitment ever, was made available to address health disparities and COVID disparities. The funds went to state and local health departments, but a very high percentage of those resources had to be obligated to community-based organizations. This year, we launched a $300 million community health worker initiative that is also now underway. And there's been $3 billion invested to address vaccine equity. So I think that the financial investments have been key, but I think that the intentionality around we have to reach community-based organizations, we have to engage trusted messengers and trusted and enduring institutions in these communities is one thing that I certainly want to be part of seeing that continue. Mm-hmm. I certainly remember, Helene, early on in the HIV epidemic, there was this engagement of community-based organizations. And what I have discovered since being involved with the pandemic is that many of those advocates are still in place, and many of those organizations are still in place, and they are very much, pressing on CDC, and I'm sure other policymakers to make these investments in those communities, and to engage those organizations. And they've demonstrated the difference that they make when, they're the voice pursuing, vaccine confidence and, increasing access to testing and helping to tear down barriers. So I think that's going to be critical as we move forward, and we hope that, you know, there will continue to be the kind of national support for that as we move forward.
Yeah. George, anything to add to that?
Oh, absolutely. So, you know, obviously the American Public Health Association, we spent a fair amount of time hopefully trying to make sure that people in the field understand the importance of engaging communities. And we teach that as part of both our writings and the meetings that we have, our academic and science sessions. But one of the things that we've begun doing a lot more of is actually bringing people from community to our meetings to engage, particularly around issues around environmental health and climate change. You know, it was real clear to me. I was a health officer in Washington, D.C. for a couple of years. And during that time period, one of the life lessons I learned was that as a middle-class African-American from a middle-class household in Chicago, I had no concepts of the life experiences of people who lived in communities that were more impoverished than the community that I lived in. And I had to learn a lot of life lessons that my staff and people in the community, the outreach workers that we worked with, taught me about, you know, how to engage folks, how to, even when you're talking with individuals, the fact that their life experiences may be very, very different than mine. One of those life lessons was once we had a bunch of young children who were going on a trip to England. And I've told this story a lot. Those kids would certainly, I thought they would be very excited about going to England for the trip. But what I did not understand was, yeah, they would probably be at some point excited about going to England, but what they were really excited about was going to National Airport.
Yeah.
Because they had never been to National Airport, and people know how
Yeah.
small the District of Columbia is. But the neighborhood in which they live, they see these airplanes coming across the horizon. They know they come across the river somewheres and across the horizon, but in a community about 10 square miles, they've never been to the airport, never seen it. And if you think about it, that tells you that many of our kids have never seen anyone that looks like them, that's been prosperous from their perspective, or have a vision of the world beyond their own neighborhoods. And so, you know, that was not my life experience. And so one of the things we have to understand, though, even though we may look a certain way or dress a certain way, we all carry our own limitations based on our life experiences. And what diversity gives you is other people's life experiences. And they bring that understanding to the table and educate you about that. And you can see things, if you listen and don't talk, you can hear those experiences and they can inform your decision-making and the things that you do. So one of the things APHA does a lot more of is try to engage communities in order for us to hear what their life experiences are to inform our work.
Yeah. No, it's fabulous. And, you know, living here in Chicago, where I wake up every morning and look out and see Lake Michigan, there are young people 5 miles away from here who say they have never seen Lake Michigan, which is one of the most, you know, beautiful aspects of living in the city. I know Charles is going to come and cut me off in about 2 minutes. So I would be remiss if I didn't ask a question about this in the global context. We are the World Affairs Council of Atlanta. All of you have had global experience in some way or the other. And I guess I would just like to hear your perspective on this issue of race and racism and public health from a global context. Why is it important that the United States talks about this? And how do you see this playing out? It may not be the exact same issues in different countries, but different countries have variations on populations that are marginalized. that are critical. So just love to hear any quick reactions from all three of you on this before I turn it over to Charles to get questions from the audience. And so Linda, maybe start with you.
Yeah, I'll just jump in. And your point is right. This in the US, we call it racism. Outside the US, we call it colonialism. And there is a huge effort to understand the similarities, but to talk about decolonizing research and education and economic opportunity. I mean, the fundamental drivers are the same. There was a group that oppressed other groups. And so we really have to work at a global level to dismantle the oppression and see that there's the common experience and the common goal and the common benefit to doing that.
Yeah, and I would just add, you know, without naming countries, but countries that I've been involved in where there was actually a denial of both race and a structure of race, and certainly then racism, that people were just whatever the nationality was. But in the face of data, it would be clearly evident that African descended people or dark-skinned people in those countries were not faring as well, either educationally, economically, and in other social ways. And so I think where we are at this historic moment is we're no longer able to say that these don't matter, that whether you accept a category of race, there is an ism. You can make it classism, you can make it colonialism, you can make it whatever you want, but there is a distinction. And so it is time, as Linda said, for us to really start to speak to that in a transparent way and start to dismantle those systems that hold that in place.
And we have an opportunity to do that. You know, the United States can become an exemplar to the world. Treating people in an equitable manner is a global phenomenon, but there are ways to do it. We can do it with the way we spend our money. We can do it with the way we treat people. We can use it with the fact that the who represents us as we talk to other nations. We have so many tools to dismantle this concept of one group of people being superior to another. We just have to do it with some intention.
So I will turn it over to Charles, but I would just to say thanks to all three of you. This has been fascinating. I could keep going on, you know, I can ask questions forever. This has been fabulous. And I just want to also just thank our anonymous benefactor for making sure that this important conversation took place. So.
Thanks, Helene.
Thank you.
This has been great. I would love for this to go on forever. I've got more questions than we can possibly answer. So this is one where I'm going to ask people who are experts and know so much to speak very briefly and tell us what we can do. And I want to tell the audience that we're going to try to send to you links to the studies that y'all mentioned at the very beginning of this program and the book that Helene mentioned so that everybody's got that. But Kim White asks, and I think it's very important, what resources are available or will be available to teach racism as a public health issue in schools of public health? And I guess I got a question. Is it being taught in schools of public health now?
It is being taught both in schools of public health. It's also being taught in schools of medicine more and more. And, you know, as like any other program, the quality of that training varies, but it certainly is. And again, it comes with a recognition that health equity is important. Now, note that some of it's not called racism. Some of it is, you know, there are courses around disparities, there are courses around health equity, but within the substance of those courses in general, racism is part of the discussion.
Okay. Eric Coleman asked, he says, some people would say racism is a white people problem. How can our white counterparts better align their actions, their attitudes, and their acumen to dismantle systems that oppress and disfranchise others?
Let me just say that it's not this I'm chuckling. It's not. It's there are lots of people. You know, we got lots of folks that look like me who discriminate against people who are darker than me. And I got to tell you, there are lots of people who have racism in their hearts, and we had a lot of work to do here.
Yeah. And if I could just add to that, and I think Linda said it early on, you know, our whole society is negatively impacted by racism. We are depriving our nation of the brilliance, of the energy, the engagement of many people in racial and ethnic groups from being able to fully participate in what it is that makes America great and how we can continue to move forward. So racism is negatively impacting every sector in our society, in every segment of our society.
And Charles, I'll just mention when at the, you know, COVID-19 is happening, and we've got the brutal murder of George Floyd, and then, you know, there's the response to that. Black people and corporations all over in just working their job suddenly became the de facto DEI expert, diversity, equity, inclusion expert, and their white colleagues kept saying, well, how do we respond to this? What should we do? And, you know, these people were not qualified. They're not DEI folks. So it became their problem to solve. So, you know, I think you're hearing a theme here. It is everybody's problem. It is not our problem to fix, but we all have to come up with those policies, practices, procedures, the very values that are necessary to understand that equity benefits everyone, instead of viewing it as something that one group has to give up so another group gets something that they may not deserve.
That's great. Andrew Staunton, who's the Consul General of the UK here in Atlanta, asks, how does this get, and I guess this is for you, Leandris, I mean, how does this information, is the CDC does studies, comes out with solutions, suggestions, best practices. How does it get from the CDC to state and county health departments across the United States? And Andrew asks, we've got the same problem in the UK. How do we internationalize cooperation on this shared challenge?
So I think that's like a multi-pronged response. One is that we recently launched what we call the Racism in Health website, and it will be essentially a repository for research that will come out of CDC, articles that will be published, even not only by CDC researchers, but, you know, we can have it as a gathering place, if you will, for other credible research that's coming out about racism in health. We're having a lot of conversations about this in the Office of Minority Health and Health Equity, as we will be working with our public health partners to also be able to figure out ways to get this information to state and local, tribal, territorial departments of public health. And one example this year, the Association of State and Territorial Health Officials sponsored a really profound health equity summit that was focused almost exclusively on racism and brought to the table like leading scholars from around the country, as well as public health practitioners who were able to speak to their own experience. And you know, also, I think we are in, you know, some conversations about how we can collaborate more globally to share our experiences, the experiences of the U.S. and the research, as well as strategies like anti-racist strategies that are emerging and that can be scaled and tailored in different environments.
Soledad Complicado, who is a Pacific Islander, asks, many communities of color do not trust the medical profession. What does the panel think would be a good way to ensure that clients, patients who speak little or no English are treated with respect and receive the support they need?
Well, it certainly takes a work of making sure we have a culturally competent workforce. So first of all, we need to make sure that we increase the number of underrepresented minorities in the health professions. Secondly, we need to make sure that both they and our non-Hispanic white colleagues are also culturally competent. And we can do that through both medical education, through working in improving their skills in these areas. But I think one of the more important parts of all of that is making sure that we deal with everybody's individual cultural biases. We all have them. Again, they're based on our life experiences, and we need to face those. And there's a lot of introspection that has to happen as part of that process.
And, while I certainly agree with George's, I tend to take a more pragmatic approach. Sometimes you have to legislate behavior. So, for example, Black maternal mortality is horrendous in this country. I guarantee you, if providers were reimbursed on the basis of maternal outcomes based on race and ethnicity, we would see those numbers change dramatically. So while I am in violent agreement with George's, yes, we need cultural competency. We need people providers, especially to understand what that means. We're going to have to help. And I think if we tie money and reimbursement to behavior, we'll see behavior change.
That's great. There are a number of questions from different audiences about what can individuals do? Are there places where they can volunteer? Are there places, how can they help? How can people impact their communities where they live and make a difference? And then I'm going to start with you.
I would say, listen exactly to what George has just said. Think about your own response to issues when you hear people say things that may strike you as racist or sexist, or you see it in public media or perhaps even in your own family around the dinner table. First, kind of think about, how does that make you feel? What is your natural response? And then do that introspection. I mean, yes, there's lots of training, but to George's point, this has to happen at the individual level, and we've got to examine our own biases, because we all have them, and really take into account what that means to the people we're talking to and our own behavior. And if we could do that, just the act of sort of stopping and listening and paying attention to what your thoughts are and how you feel about an issue can go a very long way.
Here's the last question. This is from Ambassador Thelma Phillip Brown, who is ambassador of St. Kitts and Nevis to the US. She asks, has racism prevented us from viewing drug-related violence as a public health issue?
Yeah, I got to tell you that the answer is it certainly has. It has been one of the many barriers that we have. If you see these people as unworthy, then you are unwilling to write a check to fix it.
Yeah, I also think we've not fully acknowledged how social and environmental exposures shape particular behaviors. And I think that that's part of how we can be blind to the impact of racism, because we're making judgments about people's moral character in this instance, rather than the structural and systemic forces that are contributing to particular behaviors and outcomes. And so, I think this is part of the unpacking, to use that term again, that we need to do both as public health practitioners, as ambassadors, as national and local leaders, as members of families and communities. That's the thing that we have to do. And the last thing I would say, I had a conversation with a colleague once and she made the statement about essentially not wanting to get involved with this issue. And I said, I don't have the option to opt out. I can't just say, well, I don't want to deal with that. And sometime later, she came back to me, and just that statement about, I don't have the luxury of opting out, had a real impact on her. And I can say that going forward, she was really a champion, and has been incredibly effective. So I think sometimes we have to, well, always we have to be open to the discomfort of the conversation. We have to recognize our privilege, not to be cliche here, but to just know that, you know, your silence is helping to perpetuate these injustices, even though as a person, as an individual, you know, you disagree with them. So I would just want to add that to what people can do.
And Charles, I came off of mute just to add, you know, when Leandris was talking, it reminds me of a phrase that people say, you know, when you think about some of these situations, these are normal responses to abnormal situations. And I think we have to remember and think about the social context and recognize that this is not an individual moral failing. This is around, you know, abnormal circumstances that people have adapted to in very normal ways that you and I would also do if we were in the same circumstances. And I just think that being able to flip that so that people stop thinking about individual failings and think about systems failings is part of what, you know, I think we're all talking about. Now I'll shut up and go back on mute.
Oh, don't mute yourself. This has been great. I want to thank you all. This has been one of the most impactful programs that we have done. And I'm going to invite you all. I'm going to make you commit now before I turn off the camera. So let's do this again in 6 months. Let's see what progress has been made. Is that the right amount of time? I think that would be really, really useful. I mean, we've got this large audience across the US and across the world, and I'd love to bring the four of you back. Helene's the perfect moderator, to talk about this again in 6 months. I think that would be great. So I'm going to see all of y'all in November. One more time together. I want to thank you. This has been great. Dr. Leandris Liburd, Associate Director of CDC for Health Equity, Linda Goler Blount, the CEO of the Black Women's Health Imperative, Georges Benjamin, the Executive Director of APHA, the American Public Health Association, Helene Gayle, the CEO of the Chicago Community Trust. This has been great. Hang on for just a minute. I got to do a little self-promotion here. I've got 3 requests from the audience. I want you to join the World Affairs Council. Join as an individual member. Better yet, get your company or your organization to join. And if you don't live in Georgia, become a digital member. We'd love to have you no matter where you are. To all of you, please subscribe to our YouTube channel. There's no, it says subscribe, but there's no charge, and you will get this video and the video of all of our programs. You'll get notification as soon as we can upload it. And finally, invite your friends to join one of our programs. Next week, we don't have any programs. We've got a board meeting. We'll be getting ready for that. But on June 22nd, we've got a program on travel in the post-COVID world with Melissa Lee, CEO of the Green Program, and Tara Capel, might be Capel, CEO of For the Love of Travel. I want to thank Valerie Lopez DeFrank, our producer, Laura Brower, our assistant producer, Henna Rennie, our program director, and our intern, Josephine Steenbergen. And I want to thank you again, Leandris Liburd, Linda Goler Blount, Georges Benjamin, and Helene Gayle. This has just been an extraordinary hour. Thank you all so much for spending time with us.
Thank you.
Thank you.